Hello everybody, this is Dr. Rajal Shah, continuing on the theme of a pattern-based approach to diagnosis of renal cell tumors. This is the second video which is going to focus on clear cell tumors. There are 5 major subtypes within this particular category of clear cell tumors. Clear cell renal cell carcinoma accounts for the largest spectrum, accounting for about 65 to 70% of tumors. Then the next common one is classic chromophobe renal cell carcinoma. Clear cell papillary renal cell carcinoma is a relatively recently described entity which accounts for about 1 to 4% of tumors. Translocation renal cell carcinoma also accounts for about 4% of tumors, and its incidence is kind of increasing in the sense that these tumors are now also increasingly being recognized in adults. And then provisional entity, which is renal cell carcinoma with leiomyomatous it accounts for less than 1% of tumors within this particular category. So these are the common renal cell carcinoma types within these clear cell renal tumors. I talked about clear cell renal cell carcinoma earlier in the introduction. I also mentioned to you that word clear cell is to some extent a misnomer. Many of these tumors can contain granular and eosinophilic cytoplasm, particularly in high-grade areas. Chromophobe RCC classic variant would also comprise within the common RCC types. Clear cell papillary RCC and translocation RCC are relatively two new RCC entities. And then I also talked about emerging entity, which is renal cell carcinoma with leiomyomatous. I have an entire video dedicated on this particular subject. We recently showed that these tumors harbor TSC-mTOR mutations and are similar to so-called rat-like tumors described in hereditary TSC complex. So please check out that video. And then other differentials that may come into these particular entities include epithelioid angiomyolipoma, which also would fall within the eosinophilic category or pink category, and then adrenal rest. So why this distinction matter? There are several reasons. Number one is that now we know that clear cell papillary renal cell carcinoma is essentially a benign or indolent entity with no metastatic potential. I discussed that RCC-LMS has a hereditary counterpart in tuberous sclerosis complex patients. So it is very important to rule out that hereditary complex when you see tumor with renal cell carcinoma with leiomyomatous type of morphology. And then when you are dealing with poorly differentiated and metastatic tumors, it is often very important to know whether you are dealing with a clear cell renal cell carcinoma or not, because that classification has important treatment implication. We also want to know the precise molecular classification of these tumors, and there could be potential mTOR inhibitors therapy for patients with emerging TSC-mTOR mutations spectrum of renal tumors. So how do we approach these tumors? So I'm going to give you some clues. So number one rule to keep in mind that clear cell renal cell carcinoma can contain heterogeneous array of morphologies. Practically, it can recapitulate all different spectrum of renal cell carcinomas that are known to exist to some extent focally within the tumor. So we are going to focus on the low-grade area of the tumors. And also, as I mentioned, clear cell RCC can contain pink cells. So when we focus on low-grade areas, this characteristic morphology, which is shown here in this particular image, where you have small acini lined by low-grade cells separated by very delicate, intricate branching vascular pattern, which has also been referred to as a chicken wire or racemose growth pattern, is classic or characteristic of clear cell renal cell carcinoma. And this type of morphology typically you are going to find in low-grade areas of the tumor. So extensive sampling is key for recognition of these tumors. It is also important to keep in mind that this vasculature can show you some variation. Cystic dilatation filled with hemorrhage is a very common presentation. So you may have dilated sinusoidal pattern. Sometimes this vasculature can be so prominent that the cells lining those surrounding vessels may get internalized or may not be appreciable easily, and this type of vasculature itself should raise your concern regarding clear cell renal cell carcinoma. And sometimes you may have staghorn type of branching vasculature, which has also been referred to as a hemangiopericytoma-like vasculature of clear cell renal cell carcinoma. Clear cell renal cell carcinoma also often undergoes spontaneous degenerative changes or regression changes. You can see here in this tumor there is a prominent hyalinization. So this type of phenomenon is also much more common in clear cell renal cell carcinoma. Sometimes this acini may be more nest-like or sometimes may have an alveolar type of pattern. But again, note here very prominent, delicate, intricately branching vasculature. So when you see that, I think that should prompt you to look for more lower grade areas. And if you find those classic areas, then your diagnosis is essentially kind of certain in the sense of that you should, and you can do additional immunohistochemical markers, but I think morphology would be quite supportive of the diagnosis. So let us review few cases. A 60-year-old female with newly diagnosed 10 centimeter right renal mass. She underwent radical nephrectomy. And this was a quite poorly differentiated tumor, high-grade tumor as well. You can see here that this tumor doesn't really look clear. It shows a lot more granular eosinophilic cytoplasm and also is quite high-grade. Some other areas also showed this high-grade, poorly differentiated nature of the tumor. But when we extensively sampled this area, this particular tumor, there was focally, you could see nice transition into low-grade areas, and low-grade area, as I indicated, has this very delicate, intricately branching vasculature pattern, racemose vasculature. So this is a characteristic of clear cell renal cell carcinoma, which is showing you a high-grade granular cytoplasm, high-grade nuclei with granular cytoplasm. This is another case in which you can see some rhabdoid type of cells. These cells have abundant eosinophilic cytoplasm and the nuclei are pushed eccentrically. These cells resemble to some extent rhabdomyoblast or rhabdoid tumor of the kidney. There were some low-grade areas within the tumor which again showed this classic chicken wire vasculature pattern. So again, this is characteristic of clear cell renal cell carcinoma, which can undergo rhabdoid differentiation, which is considered a poor prognostic feature, and this should be graded as a grade 4 nuclei based on the rhabdoid cells. In this particular case, there is a high-grade spindle cell or sarcomatoid differentiation, but you can see that this particular area of the tumor shows little bit of clear epithelioid cells, and when we sampled extensively focally, the tumor had classic clear cell areas. So again, the diagnosis of this case is clear cell renal cell carcinoma showing sarcomatoid differentiation. Remember that sarcomatoid differentiation is not unique to one subtype of renal cell carcinoma. It can occur in variety of different renal subtypes, and this should also be considered grade 4 nuclei based on sarcomatoid differentiation. Our second morphology clue is we are going to pay attention to the tumor cell borders. So in this particular case, you can see here that the nests are relatively larger, broad, but when we look at these cells have a very prominent cytoplasmic borders that gives it almost like a plant-like cells or plant-like effect. And this presence of these plant-like cells, one should think about a classic chromophobe renal cell carcinoma that you can further prove based on the additional nuclear features. So our clue number 3 is when you deal with this kind of plant-like cells, look at the nuclear features of the tumor cells. And presence of this kind of coilocytoid atypia in which you have degenerative binuclei, degenerative resinoid type of nuclei with perinuclear halo. All these coilocytoid type of features are characteristic of classic chromophobe renal cell carcinoma. Again, note the clear cells cytoplasm has a somewhat reticulated or frothy effect, which is also quite characteristic of chromophobe renal cell carcinoma. Our another clue on the nuclear features is that classic clear cell renal cell carcinoma, as I showed you several examples, can show high-grade cytoplasmic features or granular cytoplasmic features, but usually there is a good nuclear cytoplasmic coordinations. What I mean by that is that low-grade nuclei in cells with clear cytoplasm, while cells with granular cytoplasm has high-grade nuclei. So low-grade nuclei in clear cells and high-grade nuclei in granular cytoplasm. That is a pretty characteristic of that coordination that you can see within clear cell renal cell carcinomas. Also, you can pay attention to the nuclear polarization towards the luminal surface. This particular feature was originally considered quite specific for clear cell papillary renal cell carcinoma, but in our recent study, we showed that renal cell carcinoma with leiomyometastoma can also show this particular feature. But when you see this as a prominent feature in a tumor that otherwise shows features of clear cell papillary renal cell carcinoma, that is considered pretty characteristic feature within that spectrum, and I will talk more about that and these two entities later on as well. So I again, in my previous video focusing on renal cell carcinoma with leiomyometastoma, I have emphasized on 3 tumors: clear cell renal cell carcinoma, clear cell papillary renal cell carcinoma, and then this RCC with leiomyometastoma. All of these 3 entities can show you prominent smooth muscle stroma. So another important clue to remember is that we are going to pay attention to the architectural features, and we are not going to rely on the smooth muscle stroma to make the diagnosis. And here are these 3 examples side by side, and you can see here in all of these 3 entities there is a relatively prominent smooth muscle stroma that you can appreciate within these tumors. So if we pay attention to architectural features, renal cell carcinoma with leiomyometastoma has elongated, frequently branching tubules, but the cells lining them have abundant clear to mildly eosinophilic cytoplasm. That is one of the characteristic feature of this particular entity. In comparison, clear cell papillary renal cell carcinoma can also show you branching tubules, but the tubules are relatively small, and the cells lining them have a high NC ratio and relatively scant clear cytoplasm with apocrine, or I should say with kind of a snout on the surface of the cells. These are some of the characteristic features, but again, there could be very close call for some of these tumors, and I kind of would also recommend you to watch that particular video for more discussion on these entities. Here is another example of renal cell carcinoma showing abundant clear to mildly eosinophilic cytoplasm. So the tubules has a sawtooth type of appearance within clear cell papillary renal cell carcinoma, and it has been described also as a shark smile type of pattern, which again is not necessarily specific, but there is a kind of an interesting analogy related to these tumors. Here is a series that we had published long time back and shows a spectrum of clear cell papillary renal cell carcinoma, which can show various to some variable degree of tubulopapillary and clear cell differentiation. In general, remember that nuclei are going to be very low grade nuclei. If you deal with high grade nuclei, you are likely not dealing with this particular entity. And these tumors also often has a prominent pseudocapsule at the edge of the tumor. This slide is from our paper, which shows these three entities with variable clear cells, variable smooth muscle stroma, and variable papillary component. So how do you distinguish them? This Venn diagram shows you the overlap as well as some of the differentiating features. Both renal cell carcinoma with leiomyometastoma and clear cell papillary RCC are going to be characterized by diffuse CK7 positivity, while CK7 is usually not diffuse within clear cell papillary RCC. And then there are some of the important genetic differences as well. You don't really need molecular features in majority of cases, but in some cases it may be important to correctly differentiate these tumors. And again, I emphasize you to kind of watch that separate video that I have made regarding this RCC LMS category. And here is that link for this particular paper. And we showed characteristic molecular features as well as I think that showed that they are sporadic counterpart of morphologically identical tumors occurring within tuberous sclerosis patients. So we move to another case, 17-year-old female with a newly diagnosed 11 centimeter right renal mass with liver and lung nodules. Patient underwent nephrectomy, and you can see grossly this tumor resembles very much like clear cell renal cell carcinoma, looks quite yellow, hemorrhagic and necrotic. Yellow areas usually indicate some lipid content. We sampled extensively this tumor. Some areas of the tumor showed voluminous clear cytoplasm. So this particular area kind of reminds you of a clear cell renal cell carcinoma. In some other area, the tumor had a prominent papillary morphology. In other areas, tumor showed a prominent nested and alveolar type of growth pattern, and you can see here in this area the nuclei are clearly very high grade and also shows granular cytoplasm. A cytogenetic analysis was done in this particular tumor, which showed complex karyotype involving a translocation between XP11.2, which is the site of TFE3 gene, and 17q21, which is the site of ASPL gene. So the diagnosis for this particular tumor is MIT family translocation renal cell carcinoma. These tumors were first described by Dr. Argani and Ladani, and then there has been an explosion in terms of literature for this particular entity. These tumors originally were described in childhood and young people, but now they are increasingly recognized in adults as well. And there are translocations involve the microphthalmia transcription factor family genes TFE3 or TFEB. Most of them involve the TFE3 gene located on XP11.2. So there are a variety of partners that has been recognized. And ASPL TFE3 gene is perhaps the most common one, which resembles to alveolar soft part sarcoma tumors in terms of morphological features. So our next important clue within these clear cell renal tumors is that if you are dealing with a high-grade renal cell carcinoma, which is difficult to classify as either clear cell or papillary type, we are going to strongly consider the possibility of mid-family translocation renal cell carcinoma. And this is very, very important. Whenever you cannot classify these tumors, don't try to force into clear cell or papillary type. Think about this particular translocation associated renal cell carcinoma. There are several other unusual morphological clues that tumor can also provide you. If you see a high-grade tumor showing psammomatous calcification, stromal hyalinization, then again consider possibility of mid-family translocation renal cell carcinoma. If you have a tumor that shows biphasic rosette formation in which larger epithelioid cells and small cells cluster around basement membrane material giving a rosette-like appearance, that is also pretty characteristic of mid-family translocation renal cell carcinoma. Originally, it was described in TFEB type of renal cell carcinoma, but now has also been described in TFE3 type of renal cell carcinoma setting as well. So it is not necessarily specific for TFEB translocation renal cell carcinomas. The presence of pericellular fibrosis is another soft criteria that you can see within this mid-family translocation renal cell carcinoma. Again, and in all these examples, I showed you that this tumor is clearly very, very high-grade tumor. So if you are dealing with a very low-grade tumor, then it is not likely going to be translocation renal cell carcinoma. And immunohistochemistry and FISH analysis is clearly very important, which I will talk next about that. So here is the immunohistochemical panel that I typically use. I don't like to use too many markers. If some of my differential includes much broader spectrum within this, then you can include more additional markers: Paxate, inhibin, TFE3, cathepsin K, HMB45, and melanine. So we have talked about the utility of CK7, which in my opinion is perhaps the most important marker that you should consider when you are dealing with close differential diagnosis within this spectrum of tumors. Clear cell papillary renal cell carcinoma and renal cell carcinoma with leiomyomatous stroma is characterized by diffuse CK7 positivity, while clear cell RCC typically lack diffuse CK7 positivity. But again, the CK7 expression can be variable within clear cell RCC, so don't consider this necessarily as a specific feature. Clear cell renal cell carcinoma is typically characterized by diffuse CA9 positivity because these tumors are hypoxic. So that can be a very useful marker as well, and in appropriate clinical setting, diffuse CA9 expression would support the diagnosis of clear cell renal cell carcinoma. Clear cell papillary renal cell carcinoma has also shown to have a cup-like apical sparing staining pattern, which has been considered originally characteristic for the clear cell papillary renal cell carcinoma. But we have also shown that this type of staining pattern can focally be prominent within renal cell carcinoma with leiomyomatous stroma. Now, regarding translocation renal cell carcinoma, if you suspect that particular entity, you have to keep in mind that in general, epithelial pan-epithelial markers are going to be negative or weakly expressed in these tumors. If you have a tumor that strongly expresses cytokeratins, then usually translocation renal cell carcinoma is less likely possibility. You can also do TFE3, cathepsin K, HMB45, and melanine to further resolve your differential within this particular category. Cathepsin K has been frequently shown to be diffusely positive in translocation renal cell carcinoma. Now, a word of caution about TFE3 is that originally it was shown to be a sensitive and a specific marker of translocation RCC. But this marker is first of all, very difficult to work up in most of the laboratories and has now shown that it is not necessarily very sensitive or specific. So if you are suspecting translocation renal cell carcinoma, your best bet is to move forward with FISH analysis for TFE3 and TFEB gene rearrangement and amplification that is going to provide you the most definitive answer regarding the translocation renal cell carcinoma. And then CD10 has been again shown to be negative in clear cell papillary renal cell carcinoma, while majority of RCC with leiomyomatostroma is usually CD10 positive. So again, word of caution about immunohistochemistry is it's helpful when you judiciously utilize, but don't overtly rely on immunohistochemistry alone to make your morphological diagnosis. Here is an example of a cup-like positivity for CA9, which originally was described classically for clear cell papillary renal cell carcinoma. So these are my take-home messages for this particular pattern. We are going to focus on low-grade areas of the tumor, which is often going to provide you important clue to the diagnosis. Interpret immunohistochemistry strictly in the context of overall morphological features. Don't overtly rely on one staining pattern. FISH is necessary to confirm the diagnosis for mid-family translocation renal cell carcinoma. And if you see a renal tumor with unusual clinical and morphological features, consider the possibility of a new RCC subtype. Do not try to enforce your diagnosis into an established category. So with that note, I thank you for your attention. If you like this video, please give me a thumbs up and also share to other friends. And thank you very much again for listening.